I'm Steve Kramer, professor of neurology at UCLA. I'm a stroke neurologist, but what I think about is what happens to the brain after the stroke. This does not diminish the importance of getting to the ER, getting TPA endovascular therapy in, but look, um, we only treat with TPA or endovascular therapy 10 or 20% of acute ischemic stroke. The other 80, 90% go on with good medical care, which is good, but isn't really changing the stroke. And half of the people who are so treated still have a lot of disability afterwards. And we're not doing much yet for intracerebral hemorrhage. That may change, but for now we don't have a TPA equivalent. So, 95% of people still go on and have disability. We don't get to help them acutely. And so, in my lab, we asked the question, well, what can we do for those people? What happens in the brain after the injury is fixed? There's some degree of recovery. What's the biology of that? How can we measure it? What biomarkers can we devise to capture what's going on as people do or don't get better? And what therapy can we give to promote improved recovery, reduce disability long-term after stroke? So I call that brain repair after stroke. I think it will be ascendant in the coming years as we do all we can acutely and increasingly turn our attention to what we can do in the post-acute period. Many of us do this now, but what I'm saying is that the armamentarium of therapeutic options, I think, will increase exponentially in the coming years or decades. These are my disclosures. These are companies that are all interested in neural repair. The main points, we'll talk briefly about the biology of neural repair, and then we'll consider neural repair therapies after stroke, and then we'll consider maybe how to identify responders with biomarkers. First, I want to let you know about a study we're doing. It'll be going on for a few more months, but if you have a patient who had a stroke in the last month, give us a call. We'll drive them out to our hospital in LA, and if they're eligible, we'll assess them or randomize them, and everybody gets 6 weeks of daily arm motor therapy using telerehab, which I'll tell you about. Just give us a call at this number, or email us at this email address, or you can give the patient that information. I'll show this slide again, but we have a study going on. Everybody gets intensive telerehab, free, no charge, no insurance, and we pay the patient. We drive them out if they need it. Really make it easy. We can do Spanish language too. So, in animal studies, when there's an experimental stroke, you see all kinds of changes. Inflammation, angiogenesis, neurons are really sprouting on both sides of the brain, right? You see number of synapses in animals increases maybe a month after stroke and prunes back, just like during development. Number of dendritic branches and motor cortexes increases day 18. Even by day 3, this repair process has started. And different growth-related genes turn on, turn off. So there's a whole biology, a whole cascade of restorative events. And that's why we get this. This is Pam Duncan and colleagues. And x-axis is time post-stroke going out to 6 months. And the y-axis is a measure of arm and leg motor impairment. It's called the Fugl-Meyer score, named after the great Swedish physiatrist Axel Fugl-Meyer. 100 points is normal arm and leg movement. Some people have severe weakness. Some people have mild weakness. 80, 85% have some weakness after stroke. And what you see is that everybody gets better for a few months, especially that first month. And then they hit a plateau, living for years and years after that. And so what you saw in the animal studies is what underlies these various improvements over the first month or so. And, we want to capitalize on that and find therapies that target that and get this guy to go all the way up here instead, right? So what kind of therapies are being studied? Well, animal studies, you can do vagus nerve stimulation, growth factor injection. You can give this Maraviroc drug. It's an HIV drug, but it also promotes stroke recovery, just like aspirin works for heart attack or headache, right? There's a stem cell therapy. You can do enriched rehab. And you can do these things with a 21-day time window. Long after the TPA is gone, the brain is undergoing a whole host of repair-type events, and those are amenable to therapeutic intervention. And that's what these animal studies are showing us, that animals that get these experimental interventions have a better outcome, better arm movement, better arm coordination, better neurologic status, with 28-day time window here. So that's something. I've organized ongoing studies of neural repair. And, they're looking at drugs, biologicals like antibodies and cells, brain stimulation, lesion bypass. We see these brain-computer interfaces stories in the news. Intensive therapy, which is also standard of care, and cognitive therapies. I'm not going to have time to talk about each of these today, but I'll talk about a few examples to give you some idea about where the field's at and to showcase some of the work from my lab, let's be frank. First, let me emphasize, acute therapies are important. I'm not diminishing that for a second. I'm a card-carrying, board-certified stroke neurologist. But what are we doing in the ER? What are we doing in the endovascular suite when we're doing acute therapies? We're trying to blow up a clot. Clots are acellular jelly balls. Red blood cells have no nucleus. They're not cells. Platelets are just dandruff flaking off megakaryocytes. We're just trying to blow up this jelly ball. The target is the artery and the clot within it. That's very different from repair, where you're trying to regrow brain or grow brain circuits. Here's a corticostriatal circuit. Here's a Purkinje cell. Here's the brain. It took you 14 months to walk the first time. How would you expect somebody to walk a day later when they're affected by stroke, right? So it takes time, and it's neurobiology, not blowing up an acellular jelly ball. Both are important. So thinking about drugs, there was a lot of attention for fluoxetine. This was a little over 10 years ago. A 9-center study in France took people who were really weak and gave them Prozac or placebo once a day for 3 months. And the people who got the Prozac had a significantly better recovery. Now, they were still weak at the end of this. It's not a cure, but from across the room, anybody who works with patients with stroke would be able to tell who got Prozac and who got placebo on average, because that's a 10-point difference on the 100-point Fugl-Meyer scale. That's a big deal. What I like about this study, this may sound silly, but go with me on this. They took people who had a major problem, and then they followed that problem. They had to have major motor deficits, and then they said, how much did those motor problems improve over time? It seems intuitive, but to wit. This is a summary we published this year, just sort of how I recommend going about studying these neural repair therapies. Pick something that's wrong, measure it, and then pick people who have a problem with that thing and follow it over time. But that's not what was done here. So there were 3 massive follow-up studies to that FLAME study, and I don't think they asked the question the right way or the best way. The FOCUS study took 3,000 people with stroke in the last 2 weeks and gave them Prozac or placebo. These were milder strokes. As I say, most stroke patients have a motor deficit. And they found no effects of fluoxetine, no effect of the Prozac compared to placebo. But look at the endpoint. It's the Rankin score. Now, Rankin is good in acute stroke studies where you're salvaging, 50 cc's of brain, where you're plucking half a hemisphere from ischemic death, right? Rankin rates people from 0 to 6, where 6 is dead and 0 is normal. There's not a lot of gradations in there, but you could still pick up a signal if you're saving half the brain kind of thing. But for neural repair, maybe this isn't the best way to measure things. So people mailed in a postcard saying whether they had no disability, a little, medium, a lot. That may not be the way to see if fluoxetine helped with stroke recovery. I also don't like that they lumped everyone together here. So in this study, it wasn't pick a problem and see if that problem gets better. It was everybody come in. Vision, big motor, little motor, mood, aphasia, urination, whatever it was, whatever severity, any stroke, any size, any part of the brain, any constellation of symptoms of any severity could be in the study. And I don't think that's how we want to run repair trials. We have to pick a thing that's wrong and try to repair it, not just the word stroke, which is a very broad term. They also reduced depression, which is a big deal, but doesn't get a lot of spotlight here. So didn't really define their target population, didn't really examine people carefully. The endpoint was pretty rough. And they also didn't pair the study drug with behavioral training. We're getting in the weeds here a little, but this is an important principle in neural repair. So this is something I published a couple of years ago. What I think are some of the key principles. One of them is that it's experience dependent. What that means is you can sprinkle any magic pixie dust you want on the injured brain, but if you don't train the brain at the same time, those circuits aren't going to know how to develop, right? You give a kid who's got otitis media augmentin kid doesn't have to do like middle ear exercise. It just works, right? But you give a growth factor or a good drug to somebody who's got neural repair going on, you have to then train the brain. The brain needs training. Just because I buy you a trumpet, you're not going to be Louis Armstrong tomorrow. You got to practice, practice, practice in the basement. And so neural repair is the same kind of thing. You got to train the brain, not just give people a pill. And it's not one size fits all. If a particular circuit is utterly blown up, there's nothing left to repair. Or if a circuit is barely injured, you're not going to need a therapy. So you really have to think about how the therapy works and who you're targeting, and that wasn't done in those trials. Enough about that. Let's talk about vagus nerve stimulation. So each of you has two vagus nerves, and they are the parasympathetic signals for most of the body: the thorax, the abdomen, and the upper pelvis. All parasympathetic signaling runs up the vagus nerve to the brainstem. And over the years, nature spent a lot of time and effort getting these signals top row attention, because when the sympathetic parasympathetic balance changes, the body needs to know instantly. And so what people have found is if you stimulate the vagus nerve, you change signaling throughout the brain in good ways. We've known about this for over 10 years for refractory epilepsy and for refractory depression. It's FDA approved. And what we did was we said, well, maybe there's some sunshine there for promoting stroke recovery. It started with work from the lab of Michael Kilgard, a Mike Mersnick acolyte at UT Dallas, who found that he could make better auditory system plasticity when vagus nerve stimulation was introduced, and then found that vagus nerve stimulation could improve motor cortex plasticity. This is in animals. And then in animals with stroke, stimulating the vagus nerve improved the motor recovery. I've been consulting for this company since 2011. So we designed two trials where we had patients have a vagus nerve stimulator put on the left side, and then there's a wireless stimulator that makes the nerve fire just as the person is initiating a movement. And we had two favorable phase 2 trials, and then we had this phase 3 trial published a couple years ago that led to FDA approval. So it was a double-blind trial, 108 patients with chronic stroke. They all got the vagus nerve stimulator implanted. We turned it on in half during rehab, and we didn't turn it on in half during rehab. And then they got some extra therapy at home. And it's the same basic setup. There's a therapist pushing a stimulator, and the patient gets it stimulated at the beginning of movement, except this time, mysteriously, they have no faces. Okay, this is the main result. On the one hand, the p-value was significant. The change in Fugl-Meyer score from baseline to the end of the 6 weeks intensive therapy was 5 points in the vagus nerve stimulator group and 2.4 points in the placebo group. That difference was significant. So that's good. And we met our primary endpoint, and this was a significant result, a positive phase 3 device trial for stroke recovery. That's great. And it was approved by the FDA shortly thereafter. On the other hand, Fugl-Meyer is a funky scale. It's hard to say what the minimal clinically important difference is, but 5 might be in the neighborhood. So on average, patients had something clinically interesting, but you could get half of that without the surgery. So not really clear how to interpret this. The effect size is perhaps a bit more modest than one would prefer. If you have patients who want to do everything, this is an approved option, but maybe it's not for everybody, given that the effect size was modest. The difference between groups increased over time to day 90. And if you look at responder versus non-responder, it was about 2 to 1. Half responded with VNS, a quarter with the placebo, the sham. And if you look at a functional outcome measure, the Wolf Motor Function Test, similar. Significant difference that widened with time. And here you had 2.5-fold number of responders versus non-responders with this functional test. Okay, let's talk about intensive therapy. So in my lab, we focus on arm movement, and we like to use telehealth so that we can start in the hospital and then finish in the home, or start in the clinic and then finish in the home. And that's because it's tough for patients to get to daily intensive therapy. So we do this every day for 6 weeks, and I'll show you about this a little bit now. So activity-based therapies can have, such as telerehab or OT, PT, speech T, they have double importance. because they can improve outcomes, and that's established. And but they're also the adjuvant to many of the other therapies you see on the screen. They're the experience-dependent plasticity. So let's think about arm movement and how to make patients better. Well, in animal studies, if you want to change how the motor system works, if you want motor cortex plasticity, studies show you probably have to make 600 or 700 repetitions a day. And that makes sense. If you're doing, if I buy you a trumpet and say, play a C major scale, and you practice 10 times a day, after a few months, you're not going to sound that great. But if you practice 700 scales a day, at the end of 3 months, you'd sound definitely better or different from the other guy, right? So that's what this is telling us. And in humans, there's pretty good evidence that higher doses of rehab therapy produces superior outcomes. This is one study in which we gave people several weeks of intensive daily arm motor therapy where they had to move the hand over 2,000 times a day with the robot. And what you see, the yellow arrow, is that primary sensory motor cortex in the stroke side, on average, increased more than 20-fold, right? So this is plasticity. It's not magic. If you give somebody live therapy, their brain works differently because it's undergone plasticity. People don't get a large dose of rehab therapy like I just showed you, though. Why? Well, nobody wants to pay for it. Insurance companies are sometimes tight with they allow us to do. Access can be difficult. There may be flyover states where it's 20, 30, 40 miles to the next OT or PT. Or you might say, I know a good therapist on the other side of Pomona, but I don't have 45 minutes to get there. Patients are not compliant with pills, and they're not compliant with OT or PT or speech T, 50, 60% after stroke. And even in the best of circumstances where everything lines up, patients get a limited dose during modern standard of care. Catherine Lang and colleagues counted, and people get an average of 32. So there's 1, there's 2, there's 3. Why? Because in those 45 to 60 minutes, therapists have to talk to patients and read the chart and explain things, show them how to do the exercises. It's just not built for that high voltage, change the brain kind of thing. The therapists in the hospital are sometimes some of the best psychologists. They're really working with the patient, but you're not getting that deep, high repetition thing going on. And in fact, the whole dose of therapy is low. This is a paper from earlier this year. We followed 510 patients across 28 US sites, and we just counted how many sessions people had. And it's a dozen or less. A third of the patients in the study never saw a PT, half never saw an occupational therapist, and almost 2/3 never saw a speech therapist. This, ladies and gentlemen, is modern American medicine. And it's not good if you're a patient with stroke. They're not getting those high doses that can reformat the brain. It's not just the quantity, the quality is also important. You get more rehab effect if the therapy is challenging, interesting, motivating, good feedback, relevant. So we use telerehab to give high doses that are fun and relevant, right? And it encompasses a whole range of services, including assessment and prevention, intervention, supervision, and I'll talk about that in a minute. This is our telerehab system. This is an IKEA table with all kinds of gadgets connected to it, and then peripherals that plug in. And this lets people play different games and do different exercises and keeps it interesting. Here's a patient playing. He's holding the barcode scanner, which is used to move the cursor on the screen and shoot the ducks. Not the red ducks, the white and yellow ducks. You get the idea. And we install this in their home and connect it to Wi-Fi or supply the Wi-Fi, and it goes really easily. This may be the most important slide in the talk. These are the core principles of our telerehab, and they're informative about rehab and repair after stroke in general. We have to deliver high-intensity movement practice. As I'll show you in a moment, people are making over 1,000 movements a day, which is much higher than 32. It has to be easy to access, easy to use. You'll note that there's no keyboard, there's no flashing 12 o'clock. They just hit the white button to get started, and away they go. It engages numerous brain circuits. I don't have time to get into it, it's its own lecture, but it looks like games to all of us, but one game is tracking, which is a very parietal motor thing. Another game is like this one, don't shoot the red ducks. That's a premotor, prefrontal kind of inhibitory circuit. There's lots behind the screen here. We use games. We have 98 to 100% compliance in most of our studies, and we think it's because games are fun. Who doesn't want to play video poker or shoot aliens? And then key thing here, what's the secret sauce? Occupational therapists and physical therapists provide socialization and supervision. We're social creatures, and every other day, licensed OT or PT comes on and supervises the patient. In a qualitative study, patients really prize this. They like the human contact. This is what the patient sees. They go through video chat. We do some daily assessments. We do stroke education with Jeopardy, and then they play games and do exercises for 70 minutes a day, 6 days a week. And as I say, here's Lucy doing a video conference with a patient. Among system components, they really like the video conference the most. We did a number of smaller trials that looked favorable, and then we did this phase 2 trial. It was a non-inferiority trial. So we took 124 patients across 11 U.S. sites who were 1 to 9 months post-stroke and had a weak arm. There's that principle again. Pick something and repair that something, not stroke. You're not going to repair stroke. You're going to repair a circuit. It's at the systems level. And we hypothesized that daily intensive rehab for 6 weeks, given in clinic, would make arms work better. And if we did the same thing instead in the home using telehealth methods, that it would be comparable, that it would be not inferior. So this was a non-inferiority study, right? And the assessors were blinded. And both groups went up about 8 points on the 66-point arm motor fibrometer scale, and the difference between them was not significant. Interestingly, showing that it's not inferior to do this at home with telehealth. Interestingly, among subjects with or without aphasia, there was no difference. So we use nonverbal cues all the time, and people with aphasia had similar gains. And like I said, when we counted, we were doing over 1,000 arm repetitions a day, maybe a 30-fold increase in what gets delivered in the clinic because we've got the computer driving games over and over. So we concluded from this trial that home-based telerehab showed clinical and statistical significant gains in arm function and efficacy comparable to in-clinic therapy. Because the Rankin is used acutely, we also said, well, what happens with the Rankin? Did it improve? And so we looked at patients who were more than 90 days post-stroke when the Rankin is supposed to be at a plateau. And sure enough, the Rankin improved. A lower score is improvement in almost half the patients. So we were also improving global function in this population. Have I mentioned we're doing another study with the same telerehab system? This one is limited to people who are within 30 days of stroke. Ischemic or hemorrhagic, English-speaking, Spanish-speaking. If you have a patient with a weak arm in the last 30 days, give us a call or send us an email, or have the patient call us directly. That's fine. We take care of everything. Last few minutes, I'm just going to talk about biomarkers. This can be its own talk, and so I'm going to breeze through it pretty quickly. But the point is, we need to measure what's going on in the brain in order to pick the right patients and dose them correctly. So if somebody comes into the ER with severe chest pain, we don't just put a stent in, right? We interrogate the structure and function of the end organ, the heart, right? We might do an echocardiogram. We might, depending on the patient, we might schedule them for a treadmill. We might do a stress echo. We might do an angio. There's all kinds of things we're going to do to talk to the organ directly, not just put a stethoscope on the precordium, right? But what are we doing in stroke recovery? It's all done at the bedside. It's all bedside exam. And what I'm going to tell you in this breeze through of the last section is that measuring the structure and function of the end organ tells you more about what's going on and tells you more about treatment decisions than does bedside exam. If you think somebody has Addison's disease, you measure adrenal function, maybe a colchicine stim test or an MRI of the adrenal glands, but you don't just sit there and watch to see if their hypotension improves, when you give them replacement glucocorticoids, right? It's time for rehab neurology to catch up with the rest of Harrison's textbook of medicine. So this is just saying stratifying can be helpful. Axel Fuggemeier, 1982. In patients suited for admittance to rehab wards, visualizing the brain damage may be useful, but we don't do that yet, but maybe we will. Here's one thing that we do. So we can measure the injury to the corticospinal tract. This is the main tract that connects motor cortex with the spine and then the muscles. This is how voluntary movement is sent down to the muscles. And what we found is that the more of the corticospinal tract that gets injured by stroke, the less we can make people better by a rehab intervention. The x-axis is percent corticospinal tract injury measured using this MRI technique in patients with chronic stroke in one of our studies. And the y-axis is how much did we make their arm better with the arm motor Fugl-Meyer score. The bigger the injury to this tract, the less we can make people better. So we call this a tractopathy. Corticospinal tract injury is a factor that reduces benefit from a rehab intervention. And measuring corticospinal tract injury tells you more about how much you're about to make somebody better from your intervention than does total infarct volume, because location matters, then does baseline behavior, because measuring the organ gives you a closer explanation of what's going on than the bedside phenotype, or age, or time post-stroke, right? Another thing we measure is function of the brain. So this is one side of the brain talking to the other. Ipsilesional primary motor cortex, functional connectivity with contralesional primary motor cortex. You can measure that several different ways. This was using resting state fMRI. What you can see is, just as in healthy people, the more that the two motor cortices are talking to each other, the more somebody is in a position to learn or gain from rehab therapy. And in the same patients, the more the corticospinal tract was injured, the less we can make people better. So it's good to have a preserved corticospinal tract. It's good to have preserved connection between motor cortex and its friends. And together we could explain about half of the variability in treatment response. It's progress, but we have a ways to go. And measures of function and injury are additive for the brain, as they are in other organs. Having mentioned our trial, we're happy to do the MRI and treat the patients if they're under a month and have arm weakness. Just have them call this number. That's the lecture. Hopefully we've learned some good things about neural repair, and hopefully about biomarkers. And I'll take any questions now. Thank you.
Thank you, Dr. Kramer. If you have any questions for Dr. Kramer, put it in chat.
Yes, the current trial is only for patients who are within the stroke within the past 30 days, ischemic or hemorrhagic. If it's more than 30 days, it's going to have to wait for a separate trial. I have grants written, I'm trying, but I have to wait for a grant to hit, and we only fund 10% of those. We do have a study for gait in chronic stroke. So if you have somebody who's slow walking after stroke and they can come to Irvine, where that study is held, you can email us as well. But the arm motor telerehab is less than 30 days post-stroke. And let's see, somebody wants to, there's the information on the screen. Although I don't know if you can see it. You know what, I'll type the number in here. If you have a patient and you want to send them about stroke arm, stroke less than 30 days, arm weakness. There you go. So that's in the chat now. If they're hemiplegic, can they be in the trial? They need to have something. We need a little something to work with. So if the arm is just densely paralyzed, they can't hold the thing or hit the buttons, right? So you just have to have a little bit, just a twitch or a twitch up here. And that's part of what we screen when they give us a call. But that's a good question. If it's densely hemiplegic, no movement, then there's nothing that we can do with that. Any other questions or comments? With the vagus nerve treatment, does it help with gastroparesis on a post-stroke patient? That's a really good question. We would think that it would, because when you're stimulating the vagus nerve, you would stimulate gastric movement. But most of the movement seems to be the incoming signals to the brain, and so it changes how the brain works. Whether it changes the vagal efferent or not, I honestly don't know, and I don't know that we've looked at that. It's an excellent question, and I don't have a good answer for you. It might be. Another person says, is this only for arm weakness? Yes, my current telerehab trial is only for arm weakness. It's what we focus on in the lab. You got to focus on something. But yes, written grants to do aphasia, but the reviewers didn't want to fund them. Dr. Kramer, have you looked into psychedelics as possible neurogenesis tools? I think this is a fascinating avenue. One sees studies about psilocybin and ketamine. I think when done carefully in the right hands, this may be very important research for neurogenesis, for motor recovery for depression, mood. PTSD is a really common thing. We have a paper in Stroke this month. PTSD and anxiety, maybe 20% of patients after stroke, and it can be disabling, and those drugs might be good for that. So that's research that needs to be done. I think I've covered all of the questions in the chat. So
Yes.
thank you for your attention today.
Thank you so much, Dr. Kramer. Thank you for all the great questions.
Have a good Saturday, y'all. Hope to hear from you. Bye now.
You too. Thank you, Dr. Kramer.